Welcome, everybody. I'm really excited about this panel. You have a group of amazing, fantastic women. So please think of questions to ask and send them through the QR code, and I will ask them. I'm going to remind you several times to think of good questions, please. Rival to mine, please. So I'd like to introduce very quickly our great panelists, but I think they're also online, their bios. So we have next to me Nancy Brown, CEO of the American Heart Association, Jocelyn Fry, head of the National Partnership for Women and Families, Kate Ryder, founder of Maven Clinic, Maria Toller, who is the founder of Steel Sky Ventures, I love that name, Olivia Walton, who is a founder of Ingeborg Investments. So I would like to start out by saying that there's been a revolution in medicine, from personalized medicines to genetic therapies, genetic testing, CAR T therapies, vaccine development for breast cancer, and cancer treatments that are approaching cures. Just recently, the White House announced an initiative on women's health and health research, and along with that, $100 million to jumpstart and hopefully to transform investment in research areas from heart attacks to Alzheimer's to menopause management. There has been innovation, though, at a slower pace in healthcare delivery and in clinical practice, particularly in treatments for women's ailments like endometriosis and, surprisingly, heart disease in women and Alzheimer's. In fact, what's very interesting, I don't know if some of you saw this report by Deloitte that talks about a pink tax, that each year women, healthcare costs out of pocket, end up paying an 18% premium. And that's not pregnancy-related costs. That works out to women spending about $15.4 billion extra per year out of pocket healthcare expenditures compared to men. Moreover, heart disease is the leading cause of death in women worldwide, and yet there are still inequities in treatment and healthcare for women in that particular area, as there are inequities still in healthcare by minority status as well. So today, we're going to span the gamut to talk about how medical technology and investment in medical technology is at a really fast pace, and about the changes that we want to occur, but that also are occurring in the overall healthcare space. And so to set the stage, I'd like to start with you, Nancy.
Thank you.
You are a highly experienced leader and expert in this field.
Does that mean old?
No, I'm kidding. No, I didn't say that. Experience. These days, when we talk about women's healthcare, we first think about reproductive health. But healthcare for women goes way beyond that. Can you talk a little bit about, give us a little bit of historical background and talk about, heart disease in women, but also go beyond that?
Yes, absolutely. Thank you so much, and thanks for the honor of being here today. We like to think at the American Heart Association about health through the life course, especially in women's health. You think about the stages of health in women and really important moments in time when health status really matters. So, when we're young children, you hope that young kids are physically active and eating properly and, having safe places to play and, receiving an appropriate education. And then as young women become, start menstruating and begin the process of thinking about childbearing years, many things happen to our bodies that put women at risk for cardiovascular disease. And as a matter of fact, then, women age, they have their children, and then as they're going through menopause, that's another moment. Menopause itself doesn't cause cardiovascular disease, but it's another moment where risk becomes high for women. And so we have to think about the continuum of a woman's life and to make sure that we have solutions across the lifespan. I will say, as you said, cardiovascular diseases are the #1 cause of death of women in the United States. Heart disease causes more deaths in women than all cancers combined. And a couple of even more important statistics, I think, for all women in America, 70% of women over the age of 20 have a risk factor for heart disease. And for women who are becoming pregnant, more than 50% of women who are of childbearing years and about to start a family are not doing that from a position of health. And so we've got to do a lot, to help women have the longest, most healthful life. And I think that's really why at the American Heart Association, we have been focused on women's health for 25 years. About 20 years ago, we created Go Red for Women, our campaign to educate women that heart disease is their greatest health threat. And we did that for two reasons. Number one was lack of awareness of women about their risk for heart disease. And secondly was a lack of awareness in the medical system about treating women's heart health the same way as men's heart health has been treated. We have story after story after story of women, even today, presenting to emergency rooms and being sent away and having later a heart attack or a stroke. And that's why we've worked very hard to create women-specific treatment guidelines for clinicians to make sure that women are receiving evidence-based care at every one of those life stages.
So is that because sometimes the doctors themselves don't know what the presenting symptoms should be?
I think it is that younger women especially, there is often a sense that women are presenting with anxiety when really it's a heart attack. Let me give you an example. There is, and we're funding a huge research center at NYU, the Sarah Ross Soder Go Red for Women Strategically Focused Research Network. And they're studying a condition called MINOCA, which is MI, heart attack, without coronary obstruction. That means if you were to do an imaging test of this woman who's presenting with symptoms, there's no obstruction of the coronary arteries, yet the woman is having a heart attack. And so we're working very hard through this center at NYU to make sure to develop specific testing, including blood tests that can be used to identify MINOCA in women. That's just one example of why women are not recognized, especially at a younger age.
That's really interesting. So Jocelyn, let's add a little bit of complexity to this inequity and minority status and minority differentiation. Can you talk a little bit about the socioeconomic mechanisms that drive some diseases in women more than men and in some minorities more than others?
Absolutely, and I will, I think, really pick up where Nancy left off, because I agree with her that even with all the gains in technology, you not only have to do sort of a lifespan analysis, but you have to do sort of a more holistic understanding of what are the lives that women are leading. And not everybody lives in the same place. Not everybody has access to same providers. Not everybody has the same type of job if they're working and so forth. And so I think when you look at the data, not surprisingly, you see steep disparities across many of the issues that we're talking about around cardiovascular disease, disparities in terms of higher rates for Black women as compared to white women. That's true for cancer, it's true for diabetes, it's true for hypertension. And at the same time, if you look at the research studies that are being done often on those diseases, the threshold issue was that they often didn't include women. And then once they've included women, they often don't include very many women of color. And so that's certainly true. Cardiovascular disease, again, cancers, you see less than 5% of the participants are Black women, at the same time that they're far more likely to die from the disease. So you have that context that, I think stems from many different things, including higher rates of poverty, broader conditions within their communities. I think also we operate in a healthcare system that has steep inequities built into it structurally, and that's a reality. To the story about how patients present, there are too many examples of women of color, particularly Black women, who will say, these are my symptoms, and they will get dismissed. That's part of the reason that we see rates for maternal death, 2-3 times higher for Black women than white women, is that their symptoms are all often disregarded. And, I think it's both assumptions that are rooted in gender, but also gender and race, and sort of a narrative that, certain groups of women of color, Black women, for example, are more resilient and they can sort of bear the pain and so forth. So the reality is that the context in which they're operating is different depending on, how they present to a doctor. So if you're really talking about fixing these problems, you have to recognize the structures that are around them that we also need to repair. It's not simply about getting them or telling them better information, which is a piece of the puzzle. It's why initiatives like the one Nancy mentioned are so important. But it's also, once you raise awareness, where do they go? Right. And what do they do? And the last thing I would say is, because of all the things I just said, there also are different perspectives on the healthcare community writ large. There is a lot of uneven history, I think is the most diplomatic way of saying it, in terms of how the healthcare system has treated communities of color. There are histories in terms of, whether or not they've studies that they participated in were actually designed to help them or to hurt them. And so you have to dig beneath it to figure out, if we're really going to help these communities, what does that mean? What does that look like? I will say the positive piece is that when you look at research in communities of color, when you talk to women of color, Black women, they're overwhelmingly interested in participating in studies. They want to be healthy. They believe they're doctors. But there is a recognition that the medical establishment writ large, as they understand it, hasn't always treated them well. So I think we have to have that understanding of how inequity plays itself out if we're really going to talk about improving the healthcare and health status of all women.
I think it came to the fore a lot during COVID, when there was a lot of discussion about how a lot of women and men of color didn't want to come in to get the COVID vaccine. They were just distrustful. I mean, of course, there's a whole swath of people who were distrustful of the vaccine. But is that a lingering effect as well? It didn't change during COVID. Is that right?
Yeah, I think that's certainly a piece of it. I mean, I think, unfortunately, we have that history in our country. That being said, the data also suggests that people develop a rapport with their own personal doctors. So if you get information to doctors who are treating patients in communities of color, if you have more diverse healthcare providers, there's a way to overcome it. At the end of the day, many access the vaccine, but I think, to your point, it's important to recognize that not everybody is going to perceive, whether it's a discussion about a vaccine or treatment, the same way, in part because of the context in which they're operating and their past experience with the healthcare system.
Right. Thank you. Kate, so can you talk a little bit about Maven Clinic? First of all, tell me about the name, and why did you start it? What led you to start this?
Sure. Well, it's great to be here. I started Maven 10 years ago, and kind of reflecting on the journey, I was thinking of a lot of the structural issues. One of the big structural issues 10 years ago is there were no female investors. So the first 5 years of this business was a total slog. We've now raised $300 million, and I'm excited to address some of this today. But ultimately what we do is we're a virtual clinic in your pocket. We cover pregnancy, fertility, pediatrics, menopause, with a care team that might include OBGYNs, pediatricians, mental health providers, doulas, midwives, genetic counselors, and we have over 30 different types of specialists. But Jocelyn, one of the things you were saying, and one of the reasons we have about 2,000 clients today that we partner with to deliver these benefits, is that we have a culturally competent care model. And so virtual care is one of the big ways in which you're able to kind of at least build a little bit of trust back in that has been so lost. And so one of the things that we saw during COVID is one of our OBs on staff, Dr. Kathleen Green, she's a Black OB, she was saying that, like, with vaccines, some of her patients, they were being told to get a vaccine. They just needed to come on and hear her say it was okay. And then they went and got the vaccine. They didn't need to know about like the ins and outs of the vaccine science. And so we just see that over and over again. We published a study in December where we found that if you are in our maternity program on Maven and you talk to a virtual doula 2 times, for white women, there's a 30% reduction in C-section rates, and for Black women, 60% reduction. And it's because 45% of our doulas are Black. And so you can kind of see that there's a lot of low-hanging fruit right now in how to actually start to rebuild this trust that has been, never there, quite frankly, in the first place. But I think one of the things that as we've grown, so we do both virtual care, and then we also have a reimbursement platform for the fertility industry, but then we also use that for doula reimbursement and backup childcare. So really runs the gamut and allows payers and employers to design the right benefits for their population. But one of the things that has always been our thesis, and again, it kind of landed flat with early investors, and now they're finally understanding it, is none of this should be the case, because if you look at healthcare, which is the largest industry in the United States, nearly 20% of GDP, women control it. I mean, we dominate it. We're the ones spending all the money. And so our hope is, as we shift into ideally a more data-driven system where there's more tech-enabled solutions like Maven, as there's, AI kind of enters the fold and is able to make things more consumer-oriented, that women's consumer power here, and then in respect to our care models, will be that much more, will accelerate in terms of how we get the care that we need. Because I think, what Nancy's been saying, what Jocelyn's been saying, it's just across the continuum, starting with when you start to get a period. My husband told me my 6-year-old daughter this morning was like wearing sexy clothing. I was like, where did she even get that point of view? And it was like we don't talk about this at home. She has 2 brothers, and it's like things she sees, big girls in bikinis, I guess. She wanted to look like she was wearing a bikini to school today. I don't wear bikinis, by the way, so I don't know where she got that from. But it starts at such a young age, and then there's just so many gaps. And so I think it's really hopefully exciting. There's been major step backs recently, of course, on the policy side, but we are at this transformation moment where we can start to kind of see changes.
So do you think that women, who are going to, ordinary clinics, that they're poorly served by them, and that's why Maven does so well? Or what is it that you think is
definitely
a deficit in the normal clinic system?
I think doctors are so overworked these days. I mean, talking about provider burnout and the fact that your patient visits are being condensed further and further and further into, 12 minutes, 11 minutes, 9 minutes, because you have to do charting for those other 3 minutes. And so how can you really deliver on whole person care in a really complex world? And so for us, having this clinic in your pocket, it allows you, if you are pregnant and you walk out of your OB office, you're actually able to understand what went on. If you have symptoms, a lot of healthcare happens outside the home. If you have symptoms, you can talk to somebody. They may say on Maven, go directly back into your provider. You need to, that's a worrisome symptom based on your risk profile, but just to be able to give people that advocacy, not just from coaches, but actual doctors. And so yeah, I think it's just unfortunate. There's so many great doctors out there, but they just have less and less time. And then there are some not great doctors out there. Yeah. And also in the U.S., 30%, actually more than 30% of counties don't even have an OB. And so coming back to Jocelyn's point around if you don't even have an OB and you kind of have an old white family physician that's going to be delivering you, you can see why you don't go to your prenatal visits. Yeah. So there's a lot of work to be done.
That's interesting. Well, so Maria, you were there for the White House announcement. Can you please tell us about that?
Sure. We were really excited.
That's better.
We're really excited at Steel Sky to be tapped to work with the White House on this women's health initiative. Last November, the First Lady announced this groundbreaking White House initiative to get more money into research and development in women's health. And we were really excited to bring her down and host her in Atlanta to kind of show her what the challenges were we've been dealing with as investors, as supporters of the women's health ecosystem. And out of that meeting, we ended up then subsequently going to Boston, where she announced the $100 million sprint for women's health care. And during that meeting, we coalesced researchers, physicians, investors, investors, policymakers, and we all came together to determine what the biggest challenges were in women's health care. And during that discussion, it was very clear that $100 million was not going to be enough to solve all of the problems that we unearthed during this meeting, right? That's less than you've even raised, right? So coming out of that, then they kind of realized the need for more money, and a couple of weeks later was at the White House where they asked Congress to approve $12 billion into women's healthcare research. So we are excited at Steel Sky to play our own little part in helping progress and advance women's health research and investment. And so we've just been really excited to be able to support people like Kate, people like Olivia and I have now joined the investor framework where Kate said, there weren't women investors. We're still receiving like less than 3% of all LP dollars. We're still only getting a little bit. So that $100 million, while it seems very small on a macro level, when you see fintech getting, $110 billion in a bad year, and women's health is topping out at $3 billion in a good year, like that's just not enough to create solutions for 50% of the global population. So this is a start and a spark, as we said, but there's still a lot to do, and getting money and investment in the hands of women is going to make that change.
Well, so is this $12 billion, because I understand the initiative is for research, is this $12 billion going to also be for commercialization, or is it really focused on research?
Both. Innovation as well as research, because research is great, but we need solutions today, right? And so the research is going to change things for women in generations to come, but what Kate is doing and what our companies are doing in our portfolio are meeting the needs of women today.
And is it focused just on women's health? In other words, it can't be something that would benefit, everyone.
Well, the way we invest it can. It's inclusively women's health, probably not exclusively women's health.
Great. Okay, great. I'd like to raise the topic of maternal mortality in the U.S. And first, the numbers are really hard to come by, and they're debatable. Maternal mortality has fallen around the world by half over the past decade, and that's a great achievement. But here in the U.S., it may not be falling. So, Olivia, I know you do far more than this, but you are in Arkansas, and I'd like to hear a little bit about, how maternal mortality, what's happening in Arkansas there, if you can talk about that.
Sure. And I'm happy to be here, and great to meet all of you. Thank you. So at Ingeborg, we are on a mission to get more money into the hands of more women. And on the investment side, we have a VC fund that invests in female founders and fund managers, and we value innovation that empowers what we call the full female experience. On the initiative side, and that's nationwide, and the initiative side, I work more locally in my new home state of Arkansas, because I actually am born and raised in New York City. And there I work with philanthropy and advocacy, and the need is very severe down in Arkansas. We are the top state for maternal mortality in the country, which is defined as death from consequences from childbirth in the 12-month postpartum period. We have the third highest infant mortality rate. I believe you said the 30% of counties. We are 60% of counties. There is nobody licensed to deliver a baby. And now we have a total abortion ban. So the need is urgent, but I'm actually very optimistic that there is a little bit of momentum. Governor Sanders has come out now after a year of advocacy and announced a maternal health steering committee. We've just commissioned some research to kind of prove out the investment case. This panel is titled ROI. We've shown that the state is losing $2 billion a year because of adverse outcomes from birth and maternal health, and made like a really clear investment case. And I think for the first time they really are looking at the Medicaid reimbursement rate. They're asking themselves, what other rungs should really be on this ladder of care? Why are there no midwives in our state, which is a proven solution for safe rural birth outcomes? So yeah. It is dire, but I think there's reason to actually be hopeful that things are changing. And on the investment side, I totally agree with Kate that this is a transformative moment full of opportunity.
I do want to say one thing on maternal mortality, which blows my mind. 2 out of 3 deaths are preventable.
Yep.
Right.
Yeah. The Arkansas committee said 92%.
Wow.
92% were
They should be
preventable.
all preventable. So there's another disease that also doesn't get much talked about, cervical cancer, that afflicts far more women. In fact, 3,000 women a year in the U.S. die from it. That's like one woman every 2 hours. We could eliminate it. It is, very, eradicable, but we don't. So, why is it? It's fixable, but it's not sexy. Nancy, I think you had mentioned something about it too.
Yeah, I just read an article yesterday or the day before about this topic. To me, it is mind-blowing to think about how close we are to checking off the list, a disease that kills so many women. And what will it take? We funded the research, and with many of these things, I always like to say we are a huge funder of research. We have $500 million a year on our books that we're supporting
Much more
research.
than the White House initiative, mind you.
Yes, I will say that. So you won't find a bigger supporter of research than me, but there comes a point when there is no more research needed, and we know what to do, and so we have to get our systems in place so that diseases like cervical cancer, as an example, are checked off the list. And
I mean, HPV
Yes.
vaccines.
Right, exactly.
I mean, Rwanda has
Right.
a higher rate of vaccination of its
Exactly.
girls than here in the
That's
U.S.
exactly right.
That's just so
It is.
odd.
And, I think in the United States, as we talked about a few minutes ago, there's many complex reasons why individuals may or may not choose to take certain, evidence-based treatments or vaccinations that could cause a different outcome for them or for their families. And I think we have to keep at it. We've got to keep educating. We have to make sure that the community owns these answers and solutions. This cannot be someone from above saying you have to do this and this and this. It needs to be of the community. And when these solutions are of the community, the adoption rate will be so much higher.
Yeah. So I'd like to talk about clinical trials because that certainly is really important. Every drug and device has to get through those clinical trials, and a lot of them historically were done really only on men until Congress finally mandated by law that you had to include women in clinical trials. But it's kind of still not at 50-50 where it should be. Can Jocelyn and Nancy, can you talk a little bit about the clinical trials and participation in them?
Yeah. I'd be happy to start. Do you want to go ahead, Jocelyn?
I'll start, again, I'll pick up where Nancy left off, and I will reinforce a point that she made, which is I think, whether you're talking about clinical trials or really any of the solutions that we're talking about, you have to ask the communities that you're serving. Right. I think we get into a habit often as particularly communities of color, particularly low-income communities, particularly immigrant communities, we go for stories, but we don't go for solutions. And a lot of times they'll tell you what the problem is, and they'll tell you this will address it, right? Like they may not have all the technology, but they'll tell you if the problem is there's no provider, within the bus route. Right, or that there's no, there's a, OBGYN, but nobody ever goes to him or her because they often don't like people in our community. Like they'll tell you those stories. So you need to actually, if you're really talking about health equity, which people are talking about a lot, you need to actually make sure that you're talking to the communities that you're trying to serve. And I think the same is true when we're talking about clinical trials. And you're absolutely right. The history has been that they were often, focused on men and usually white men, and there has been work, and credit to Dr. Biden, who's leading the initiative to really try to broaden our understanding of the research that needs to be done. But even today, because of I said earlier some of the history around clinical trials, you have to do some work to make people feel comfortable with participating. But there is research I think done by the National Medical Association that shows that at least among Black patients, they're certainly open to participating, but then you have to reach out to them. You have to make it available to them.
Can you talk a little bit about the history that does, give them a lot of pause?
Unfortunately, we have, a terrible history of the medical system using communities of color, particularly Black patients, for tests of diseases that they know that we're giving them, leading to death. The eugenics movement, right? There's like a whole sordid history around medical malpractice when it comes to communities of color and treating their bodies like receptacles for experimentation as opposed to treating them like human beings. So hopefully we're past that, but that history doesn't just go away, particularly if you don't confront it head on. And I think one of the realities of this moment, and I appreciate the other panelists speaking to this, is that you can't fix a problem if you don't confront it. Right? Like, it's just not going to work. And so the reality is that we live in a country that's a wonderful country, but it also has racism, it has sexism, it has all sorts of bias, and all of that influenced those sorts of experimentation and clinical trials that were harmful to communities of color. So I think you have to tell people, we own it, we know that this happened, we've taken steps to do something different, we have a different model. I think my view of focusing on women of color in particular is that if you solve their problems, you're usually solving everybody's problems.
Absolutely. Yeah. That's right.
And so it's not just that you're helping Black women or Latinas, you're helping a whole bunch of folks because you're addressing multiple barriers at the same time.
Right.
So if you can tell that story to people, if you can get the local doctor that they trust to say, here is the opportunity, we're actually trying to focus on you and understand your wellness, then I think you can move past it. But if you gloss over the mistakes of the past, people don't trust you. And I think in this system, there is a need to build trust. Particularly at a moment where we are dealing with a whole host of challenges in this country, right. One of which is how well we are capable of confronting some longstanding problems, whether it's around race or gender, LGBTQ status. And, separate and apart from that, I think what people will trust is honesty about here are mistakes, but here's how we're trying to do better.
Right. Nancy, please.
Yeah, and I might just add, I so appreciate every one of those points, and we think about them very clearly at the American Heart Association for the role we can play, and I'll come back to that in a second, but let me give an example that really, I think, catches the attention. In addition to the many things we do at AHA, we host the world's largest scientific meetings in cardiovascular disease and in stroke. And at every one of these meetings, late-breaking clinical trials, we call them, come forward for the first time the results are presented. And at a meeting last November, I'm not going to talk about the company or the investigator, but there were thousands of people, standing room only, simultaneous publication in JAMA. This huge trial was presented at our meeting, and I was sitting right next to one of the legendary clinical trialists in America who's on my board, and we're watching the investigator, we had seen the embargoed results, but we're watching the investigator present the results, and he puts up the money slide, the slide that showed that this new drug was effective in this particular case and for this particular subgroup of people. And, my heart just dropped, because here on this slide that should have had more than 50% women because of the type of trial it was, had fewer than 30% women, and of that, fewer than about 15% were non-Caucasian women. And then, so of course I go digging around, the advisory board for this trial had no women on it, no women on the advisory board for the trial. Like, this is 2024, it was 2023 then. Like, how in America does this happen? And so, I say that to say that the problems are big, and it does start with trial design. Like, we can talk about who's in a trial, but if you don't start at the beginning with trial design, you do not get the right makeup of the trial. Now, some of the reasons it's difficult to recruit in clinical trials are that most clinical trials are recruited in academic medical centers where fewer than 10% of people in this country receive their care. It's very hard for a clinical trialist to go to Bentonville, Arkansas, as an example, and recruit people for their clinical trial if they're not in an academic center. One of the things we've done to try to upend the system, we've created a registry called Research Goes Red. It is a clinical trials platform that women, we use the broad, 44.5 million volunteers and supporters of the HA. We recruit people in. They are consenting and participate to agree to be part of research. They help us with very study designs, things that matter to them. And it's built upon the 2,400 U.S. hospitals that participate in our Get With the Guidelines program, of which fewer than 200 of those hospitals are academic centers. So this is a big part of how we're trying to solve the problem.
Right, wow. Well, Kate, I'm just thinking that you have 2,000 women as clients. Maybe you can start feeding them to some of the clinical trials.
2,000
Exactly.
2,000 employers, yeah.
Oh, okay, yeah. Well, that's even more. So, so can you talk a little bit about, you had mentioned distrust that women have of the system, and then when they see your doctors, they feel a lot more trust. Can you talk a little bit more about that, and how can other clinics, adopt a better model where they can actually create more trust? 9 minutes is 9 minutes, but there are other ways to actually, if you see the doctor every single year, even if it's for 9 minutes, at least you've seen them for, about an hour every 5 years or something.
Yeah, I think, I think that if you look at a lot of the startup clinics today and how, if you're building the model from scratch, what does that look like? A lot of, every single clinic has some kind of virtual care component and a tech-enabled service alongside it, right? And so I think that's kind of a good proxy to look at, okay, in the models of the future, where do we need to get to? Because that poor doctor who has no time to just see the volume of patients that they need to see, how do we then help the doctor with better EMR and practice management systems, but then how do we help the patient get all of her, her extra care and extra questions answered and extra support, so that it's just fully a coordinated system. And so, menopause is a great example of one of the categories in women's health. We built our menopause product and we launched it in late 22. It's our fastest growing employer product. More than 450 of our clients have launched it, globally, not just in the U.S. And the reason that product was such a kind of commercially so in demand, because unlike fertility and maternity, when we sell that to employers and health plans, they're doing hard ROI models with their actuaries to understand, okay, where's the cost savings that you're going to drive if I incur this extra cost of bringing on a Maven? And so we really have to kind of prove that. With menopause, that's not happening because a lot of the HRT being prescribed for menopause, there's no claim associated with it. And then when you get into why is this such a fast-selling product, well, a lot of times OBs just were never trained in menopause in the first place. So there wasn't even an in-person provider they could go to often, and that was what we were hearing from so many patients that actually knew how to treat symptoms. A lot of it was, all women go through it, just get on with it. And so that's been a really exciting product, because what we've seen is, just by kind of documenting what are a woman's symptoms, and then connecting her to OBs who are trained in menopause, who can actually kind of unpack, this is a nonlinear journey and every woman's different. And so how do we actually treat you? And some women need HRT. We've actually found that, we did a study of 7,000 of our menopause members, women in our program last year, and we found that weight gain was the #1 symptom. Mm-hmm. We found that when they came looking for HRT, that actually 60% of them ended up getting an HRT prescription, but 40% didn't because they didn't need it. And so HRT is one of those things too that has popped up in menopause where it's that's going to be the silver bullet. You just take those hormones and you're going to be fine. When, actually maybe you need sleep medication, or maybe there's a diet adjustment you need to change. And so, menopause is a perfect example of how even in the bricks and mortar system, it's not like you're getting treated, and virtual can actually really step up and support. Some of the pushbacks sometimes we get from the health plans, when we, on the maternity side, when we're proving out our model there, we'll be I don't understand why women need this. You have a doctor. I'm right, well, every single woman hopefully has a doctor, and do you think our system works? Let's unpack. And these are OB/GYN medical directors. I'm sorry, have you checked last time what it's like for a female patient in the healthcare system? So, I think that, but when you really get into it and you start to show all of this data, this engagement data from the patients, what they're asking for, you quickly can actually change minds, because then you're like, oh, right, like that makes sense.
Does the AHA do guidelines on menopause for women?
We have clinical practice guidelines, and there are women and heart disease guidelines that reference the risks that happen to women during menopause. Right. But, I'm going to take it back to our scientists. I think it's a good idea to write menopause.
Collaborate.
Yeah,
Good.
totally. I would love
there
that.
You go. Excellent.
I think
Thank
there's
you.
such a linkage that we're even seeing from our patients. It's not just about like 90-day symptom relief, but it dovetails with aging, longevity, preventative health, and there's so much that can be done there. I'd love to talk to you. There you go.
Yes,
Yeah,
partnership in the making. Thank you for that.
Yes, so Maria and Olivia, I'm, not perplexed, but just in awe of all these new different innovative things going on here. So LARCs helped reduce teen births by about 70%. And now we've got Phexxi, Nextstellis, Slind, Turla. I mean, all these new contraceptives with just these wild names. Can you talk a little bit about some of the innovation in reproductive health? What are you seeing in you want me this one?
Yeah, I want to get back to the menopause one.
Yeah, because I want to go to the other end of our lifestyle.
Yeah. We talk so much about that, but what Kate said is really going to unlock value for investors as well. These gaps in care that have been overlooked for so long is what gets Steel Sky really excited, because we know that there's pent-up demand for this. The menopause company we invested in just 2 years ago has had astronomical growth, MIDI Health. They just raised a $60 million oversubscribed Series B in a down market because of all the pent-up demand. There's no solutions out there. There's going to be 1 billion women undergoing menopause by next year. There's 10,000 women turning 65, or 10,000 boomers turning 65 every day. There's no solution.
But are there new innovations in this area?
There's tons of innovation.
Oh, there is. Okay, talk about some of them, please.
But we can't fund them because we don't have enough money between Olivia and I. And the rest of the women's health dedicated investors, we manage less than $1 billion, right? And so that's not enough. But it gets us excited because we're going to start showing ROI. We're going to start showing graphs that go up and to the left. She's going to IPO, MIDI's going to IPO, and that's when all the other investors will jump in. But right now, we're still proving out that thesis. But that's really exciting. It's finding these gaps in areas that have just a lot of opportunity because they've been overlooked for so long.
So can you give us some examples of some of the innovation in the menopause area?
Sure. Also, so pelvic floor physical therapy is a really big opportunity in the market. We invested in a company called Origin that has both physical clinics and also nationwide, national virtual clinics. And so this is a standard of care in places like Asia and Europe, but not in the US. So when women are giving birth, they're saying, you really need pelvic floor physical therapy, but there's only 3% of physical therapists trained in that. So good luck finding one, right? So we invested in the first company that's doing this at scale. They have over 20 clinics and locations, and those are the types of things that men aren't going to find, right? There's like less than 10% of female investors, right? The men don't know what endometriosis is. They don't know what PCOS is. They sure don't want to talk about pelvic floor. And so that's why we need more women investors, because we're destigmatizing and having these conversations on national stages and now global stages. And that's what's really going to change and move the needle.
Yeah. And Kate is an example of some of the incredible innovation in menopause right now. MIDI, we're also an investor in, is another example. There's several companies in our portfolio that kind of hit this menopause space that we've been talking about, has this huge unmet need. Half the population is going to go through it. 25% of the workforce are women of perimenopause or menopause age. Women are at a time in their life where they typically have some disposable income, and they're willing to throw a lot at this. The majority of women who actually go to their doctors to ask for some kind of treatment for menopause don't receive any help whatsoever. And the studies show OBs typically get a handful of hours of training on the subject alone. So the stuff that Kate's doing is huge. We hit it in other ways. For example, we have a company called Attention Grace, which is urinary incontinence products, which is an issue that affects speaking of pelvic floor, 16 million Americans. They're already in, I think, 16,000 stores nationwide, and they've seen huge growth. We're also excited about, I don't know if you've heard of a company called Flow Living, and a woman there, I see some nods. There's an incredible woman over there named Elisa Vitti who's going really deep on the science of hormones and also bringing it back really to diet and lifestyle interventions that are synced to our cycle. I mean, these are things that women intuitively understand, and they are investment opportunities that men have been missing. So I think this is a really exciting moment. We have this public funding, which is now, going to subsidize some research, and that we often see in VC that it takes, some government funding, some public sector investment to kind of spur innovation and then VC activity. We also see more women than ever who are starting these companies, and more women who are in a position to make bets on them because men have been missing these opportunities. And you just have this incredible unmet need. So we've got science coming, we've got data and technology, and we have, this wonderful contingent of women who are really curious consumers who are demanding more and better options. And I really believe, like many of us, that VC is one of the greatest engines for change, and that's the way we're going to get the biggest return.
Okay, so we've got a slew of questions.
Okay.
One of them that I'm going to talk about then is just pertinent to this topic. So, all right, we've been talking a lot about women and women's health, but what about bringing men into the equation? How do we want them? How do we bring men into investing into women's health? I mean, look, this is all a partnership. We're not going to have any babies if we don't have the men too. So how do we bring them
Actually,
along?
people are working on that.
Yeah. It's not a women's issue. It's an economic issue.
That's right.
The single best thing we can do for our families, for our societies, and for our economy is to make sure that women are healthy and financially secure.
But for instance, in VC, how do we get more VCs, which tends to be an industry dominated by men? How do you get them to invest more in women's health
We show
ventures?
them the return. It's about money at the end of the day for all the investors. And I don't care. They don't have to love menopause. They don't have to love, birth control to your home. But they do have to love making money. And if I can show them that they can make money, then we will get more investment.
Well,
And if they don't feel comfortable finding the solutions themselves, they can invest in people that can. So we have a lot of other funds invested in us that are run by men because they know that they're going to miss the boat and they don't want to. And so they invest in us because we understand the market a little bit better.
Okay,
Well,
sorry,
and
go
I
ahead.
was just going to add. I mean, I couldn't agree more, and I think you see that in the in the corporate sector as well. I mean, the business bottom line is what drives better policies around paid leave, maternity leave, because they know that they're not going to retain, in particular, women workers, and unless they have sort of more diversity in the policies that they provide. So I do think, from our perspective as an advocacy organization, it's all of the things. It's making the business case. It's also making the policy case. It's doing all of those things. And if people are actually paying attention to the bottom line, we would always argue that they're going to do better. They're going to have more productive employees. To Olivia's point, if you look at, just the economy of families generally, more than 2/3 of moms are workers. They're breadwinners in their families. It's even higher. More than 80% of Black moms are breadwinners in their families. So making sure that they're healthy is an economic issue not only for them, it's for their entire family. And I think, in truth, when you explain it that way, men get it. It's like, issues like equal pay. They want their wives and their kids and their daughters and their sisters paid fairly because it also makes sure that they're stable as well. So I think we can make that case.
Well, so
33% of our users are men, by the way.
Excellent.
So a lot of the payers look at gender-based care programs. So you have maternal health and whatnot, but the employers actually don't want to launch gender-based programs because it's not perceived as inclusive. And so our fertility product, both men and women, our maternity product, we bring dads into the mix, and we actually see quite a few in the pediatrics and kind of postpartum period. The only weird thing was when people were trying to make a case for male menopause, and so our chief medical officer was like, "No, that's not science. That doesn't exist. Menopause, just let's help women and just own it as a women's health issue." But yeah, it's
That's just an old-fashioned midlife crisis.
right.
Actually, you know what? You've got a midlife crisis product now, right, for men. Okay. Joss, I want to get back to one of the questions here pertains to something that you were talking about. So recognizing that healthcare costs are literally killing women, what is the single big idea that could help save the greatest number of lives of low-income women in this country? And you had also talked about the squeeze, in that a lot of these women also have lower, income. Just, there's an inequity in just pay. And if they're single moms, they have even, a lot more of a burden. So do you have any sense of that? And then I'll open it to the panel, too.
Yeah, I would say a couple of things. And I think it picks up on actually something Kate said earlier. Some of the work that we do is in an area that we call health systems transformation. And it is about rethinking the models of healthcare delivery to be focused on quality and not fee for service. It really gets to your point about people going in. The doctors have people come in for 9 minutes because they're on a fee for service model, right? Like that's the traditional model. But if in fact they were paid according to quality care, and whether or not they were actually meeting the needs of patients, they might function differently. So I think to the extent that there are new models that are out there that are really focused on sort of rethinking how healthcare delivery happens, that's helpful. I think that, to the extent that we are broad in thinking about who can provide services, that's also helpful. When we talked about midwives and doulas and sometimes people in the local community who are trusted providers who can be trained to deliver, meet a range of care needs. That's also helpful. There are things that the administration has done around prescription drug costs that have gone down, particularly around things like insulin and where you have, Black patients generally, Black women in particular, who have higher rates of the disease. That also matters too, and so we certainly support those sorts of intervention as well. I think all of those things are enormously helpful to the extent that, I think most states now, almost all the states now have adopted an option so that Medicaid is available for a year postpartum for folks who are using
Not us.
Medicaid.
I was say only. No.
There's almost everybody.
40 states.
Right. I think so we're getting there, and there are a few the folks behind, but for many of the folks in the country, that is true. I think those sorts of interventions are helpful, and we have to be intentional about it.
Right. Well, so Olivia, you meant, all right. So what does one do in Arkansas? What is that?
Well, it's exactly what Jocelyn's talking about. A lot of it, where the rubber meets the road is on payment, and specifically on the Medicaid reimbursement rate. So over 50% of births in Arkansas are on the reimbursement rate. I might botch this, but my understanding is the way things are now, you get paid the full fee for delivering a baby at delivery. And so we need to, first of all, raise the reimbursement rate to actually incentivize more providers to come into the state. And we need to reimburse the other rungs on that ladder. So we need to make it so it's possible to reimburse for doula care, make it possible to reimburse for midwife care. And we need to actually start training some of those missing pieces in the workforce, because as I said, there's nowhere currently, although we're just changing it now, where you can get trained to actually be a midwife in the state. So I think those things are going to make a huge difference. And then it goes back to a lot of the underlying health things and social determinants of health, which both Nancy and Jocelyn are working on.
Mm-hmm. Great, okay. Yeah. So there's another question about food as medicine. What is the treatment? What role do you see nutrition guidance playing in women's health? Women tend to be focused more on nutrition than men. Are there, better standard guidelines? I mean, I think everyone just does Dr. Google and just,
I could talk about that. We're very proud at the American Heart Association to be partnering with the Rockefeller Foundation and Kroger and a number of other organizations to create a $250 million research initiative to create the definitive evidence to prove that food is medicine programs, when integrated into the healthcare system and when prescribed like drugs or other, healthcare provisions that are reimbursed, can both improve health and reduce costs. Now, you hear a lot about food as medicine programs, and there are some great pilots and programs that are happening in spots around the country. But as I've learned from Dr. Kevin Volpe, who is leading this work for us, he's at the Wharton School, a behavioral economist and a physician, behavioral economist. You know, when you look at all of the data, these programs are short in duration. They are, it's very unclear, you know, what people need the programs for what period of time, which foods, is it delivery, is it this, is it that? It's like mind-blowing. So we have right now created a central data repository to capture data from every Food is Medicine program, as well as the ones that we're funding. We've had a meeting last week with 120 investigators that we are funding in teams to look at a number of these pilots. And at the end of the day, and I think it's the same on the last topic that we were speaking about, it comes down to individual behavior, because in some cases programs are available to people and people are not availing themselves of the benefits. SNAP food coverage is a great example of that. So, and I think, you know, of all these great technologies for women's health, we've got to make sure women know about them and take advantage of them as well.
On that point as well, and it's so cool what you're doing, Nancy, is in our maternity program, 40% of our members are high risk. The largest driver of that is actually obesity, right? And so we actually see a direct linkage to our members in our high risk program for that reason. We have certain amount of dietitian appointments that they have along the way. We just proved out that in a Fortune 25 employer, through a hard claims-based analysis, that we were able to save 14% per member on maternal health, just maternity healthcare savings, and that's all related to preterm birth and NICU spend. And as we really looked into our data, you know, like that dietitian nutrition appointment and, you know, and then that care plan against it was a big driver. So food is critical in maternal health as well.
So Miranda, Olivia, are you seeing companies that are, you know, trying to develop food as medicine? Are those interesting opportunities?
We started to see a lot over the last 3 years popping up and getting investment, and it's kind of, but is that the most urgent thing right now, right? Exactly, because if you're a woman on Medicaid, you're just trying to go to work, get your kids to school. They're not able to afford healthy food. And so I do think by involving the health insurance plan and be able to write prescriptions for this that can serve this community, I think that can change the needle. But right now, food as medicine is only for people that can afford those things, and we want to make healthcare accessible for all.
Yeah, that is a great point. And we have an investment in a company called CHIO, which is meal delivery kits for fertility, pregnancy, and postpartum using Eastern nutrition philosophies for delivering food to women who, you know, need that nutrient medicine at a really critical time. So I have seen some things come through. In addition to obesity, the other major underlying condition that leads to maternal mortality does seem to be mental health, which is such a critical part of maternal health. And we're also seeing a lot of innovation there, telehealth care services and others that I think that give me a lot of hope. Yeah.
So I want to raise a topic that I don't know, well, I'm curious what you all think. So in the U.S., women live average age 79 years and men are 74. So even with the healthcare inequities, women are still living longer. Is this, are we, suggesting that maybe women would live to average 82? Should men be offended that, we're not actually spending more time, thinking about how to address their, shorter lifespan?
Well, I would say on that note, we have spent decades worrying about men's health, and it's about time that we take that disproportionate effort and put it onto women's health.
Yeah. Ditto. Yeah. I think absolutely. I mean, I think I take the data with a little bit of a grain of salt. Everybody's life expectancy has grown over decades, right? So I think, I'm all for men catching up, but not at the expense of us actually trying to focus on, making sure that we're focused on women's health as well. And so, at the end of the day, I'd also say from that perspective, we've done so much to invest in men's health. And if it hasn't been working for them, maybe we should do something different, right? Like, I mean, if they're living shorter lifespans, but yet all the clinical trials and all the research has been focused on men, maybe they'll be better off if we just focus on the women, right? Like, it goes to the point I raised earlier. Maybe if we're solving for different sets of problems, we'll come up with solutions that actually work for them.
But I think with genomics, though, it's just going to be personalized medicine, all around. So I think hopefully we don't even have to be distinguishing as much anymore in the future, because whether it's cancer or innovation or heart disease, I mean, what we're talking about now is women have been way too, left out of the research paradigm. But I think going forward, it's really about that personalized medicine based on your underlying genetics and who you are, and so. Hopefully that's where we get to.
And I would say just because women are living longer doesn't mean they're living better quality lives, right? Yep. We're still suffering from menopause. That's taking people out of the workforce. That's being foggy. That's tearing families apart, some of the stress from going through menopause. So I would say that doesn't mean we're better. It just means we're living longer. And I think that we need to address so that we can have better, longer quality of life. And that still hasn't been fixed for us yet.
And I would say that investing in women helps everybody. And I really believe that this window of investing in maternal health is kind of the most impactful intervention you can make. For many women, it is the most consistent engagement they have at any point in their lives with a care provider. So from a public health perspective, this is really your best shot to change the trajectory of that woman's health, of her children's health, and of the whole family's health.
Great. Well, this has been so amazing. I'm just going to let you do one row, each one word that you want to leave the audience with to remember this.
Hope.
Okay.
Persistence.
Don't accept the status quo. Sorry, that was me. Okay. Said it fast, as fast as one would say one word.
Invest.
Invest in women.
Okay, great. Well, thank you so much. What an amazing panel. And thank you for all your questions. I'm sorry I didn't get to all of them, but...